That's not good. Anyway, I'm assuming you guys got my messages about the two missed lectures, and just my decision to give you those lecture notes and proceed with the exam on Friday. I know your therapeutics exam got moved, right? So hopefully you got enough time. So anyway, what I wanted to do today is just go over the highlights of the two missed lectures. It was kind of, I suppose, as serendipitous as it could get, because for both of these lectures, they were fairly short lectures, and I was going to go over the cholinergic and the adrenergic worksheets after I gave the lectures. So obviously none of that happened. So we'll just go over this today. I'm going to just hit the highlights, really. But the serotonergic lecture, which I'm doing first, that kind of fits with the earlier lectures that are really background, lectures along with the cholinergics, adrenergics. And then the local anesthetic lecture, as you'll see, is fairly specific. And local anesthetics aren't the most complicated thing in the world. There's like one mechanism of action that we'll go over. So presumably having you guys review this stuff mostly on your own and doing quick lectures won't negatively impact things too much. And also, and I forgot to bring them down, up in my office I have like some sheets with those worksheets that are unfilled out. I don't know if you guys would want to use those just as practice, but maybe I could get somebody to run up to my office and grab them. Anybody willing to go up to my office and grab one? You know where my office is?
No.
310?
It's
310?
321.
310, no. That's my old office. 310 next to House Connects.
Oh.
So if you go up next to House Connects and then go look, just walk in, and in the back on the computer, just behind on the desk of the computer, there's a stack of those worksheets that are in color even, so you should see them pretty obviously. If you don't mind, I'd appreciate that. That way we can get them handed out. So I know folks will take off before you get a star by your name. All right. So, and I will get going with the serotonergic stuff. Okay. And also along with the serotonergic stuff, because you don't get it anywhere else, I'm just going to really briefly touch on the mechanism of action of migraine drugs, because lots of people have migraines, and I'm sure you guys, if you're working in pharmacy and what have you, have been probably already encountered drugs for migraines, like Triptans, that sort of thing. So just going to briefly go over the MOA of that. Okay, as you know, you've already been over serotonin presumably quite a bit in terms of its actions in the CNS and its involvement in depression, that sort of thing. Serotonin is a major neurotransmitter system that regulates a lot of things at the level of the CNS. Also regulates a lot of things in the periphery as well. And I think of serotonin in particular, I think it has a lot of actions in the gut. Okay? And so what I really want to do right now is we're going to discuss those actions in the drugs for GI issues down the road this semester, but right now I want to just do an overview so everybody will be kind of on the same page when we get to there. And this god-awful, ugly slide shows some various serotonergic actions in the body and the receptors that are involved. Okay, and it's really up here just to show you the complexity of the serotonergic system. I'm not going to have you memorize this or anything like that, although you could use it as a reference. But the big idea with this is when you're giving somebody a serotonergic drug, even if it's for depression or what have you, whatever, monoamine oxidase, if you're increasing serotonin levels in the brain, you're also increasing serotonin levels typically in the periphery, and you're going to have quote-unquote side effects with that, okay? So big picture, serotonergic drugs, do a lot of different things. You got it? Okay, thanks. We can just leave them there, and then you guys can pick those up if you want them as you leave. Okay, so serotonin does a lot of stuff. Okay, as you know, serotonin is also known as 5-HT, 5-hydroxytryptamine. It's a monoamine that's synthesized from tryptophan. Okay, it's got a lot of different sites of action. In this brief lecture, I'm going to go over its actions when it's released from enterochromaffin cells, particularly in the gut. It also has actions on platelets, actions on smooth muscle, actions on the cardiovascular system, and the GI tract, and of course, what you've already gone over in the CNS. Okay, this slide shows serotonin synthesis. Whoops. And let's see if I can do this pen. So the rate-limiting step in serotonin synthesis, and what you really want to know, is going to be the actions of tryptophan hydroxylase. Okay, that converts L-tryptophan into L-hydroxytryptophan and starts the cascade that gets you down to where's serotonin here?
Is the third one down?
Third one down? Okay, thanks. Third one down. Another thing to be aware of, though, so you just want to know tryptophan hydroxylase is a rate-limiting step. Another thing you want to know, though, is that serotonin in the pineal gland gets converted to another agent that you've probably seen in the pharmacy, which is melatonin. Okay, melatonin secreted from the pineal gland when? You guys know?
Good.
When's melatonin secreted? At night. Yeah, when you're sleeping, it's involved in sleep-wake cycles and regulating sleep-wake cycles, and presumably you talked about the melatonin agonist, I believe it is, that works below the hypothalamus as a sleep aid. Right. Okay, so but serotonin, again, rate-limiting step, tryptophan hydroxylase, and it gets converted to melatonin as well in the pineal gland, which acts as a hormone and has other effects. Okay, this slide says in very bold letters, systemic levels of serotonin can be pharmacologically manipulated. So if for some reason somebody doesn't have enough serotonin around, you could try and manipulate levels pharmacologically, and we're talking systemic levels. For instance, you can increase or decrease tryptophan in the diet, and that will affect 5-HT levels. You can also inhibit tryptophan hydroxylase, and that will decrease 5-HT synthesis. SSRIs, you've been over, that's going to increase the amount of 5-HT found in synaptic clefts, and that's going to be, in the CNS, but that'll also happen in the gut and elsewhere. And then monoamine oxidase inhibitors, which you've also presumably discussed previously, can increase synaptic cleft 5-HT. Okay, there's tons and tons of serotonin receptors that have been identified. I think like 30-something, some crazy number like that. The next couple of slides, this slide and the next slide, I've just identified the main ones that are talked about pharmacologically, the main classes. Okay, and I've put big stars by the ones I think you should know in terms of what they couple to. Okay, so first of all, back up, almost all serotonin receptors except for 5-HT3 or G-protein coupled receptors. Okay, 5-HT1 receptors couple with GI, and they're often found presynaptically. Okay, often, and they also are found as autoreceptors, right? So when these guys are activated, it's going to have an inhibitory effect. So you decrease cyclic AMP second messenger signaling. 5-HT2 receptors coupled to GQ, they're found in the brain, where they're involved in things like regulating feeding cycles, satiety. Also found in GI system in the gut. Okay, 5-HT3 receptors, these are ligand-gated ion channels, and they gate for cations, or you can think of them a little bit like nicotinic receptors. So when they're activated, you're going to get rapid depolymerization of the cell that's expressing those, and they're located in the brain as well as in the gut. 5-HT4 receptors, which are targets of some gut drugs, they couple to GS, and they're located throughout the body. And as I said, they're the target of some gut GI drugs, so you want to be aware of that. And then there's 5-HT5, 6, 7, and all kinds of subtypes that are out there. But those first four, I think, at least through this semester, if you can remember those guys and what they couple to, you'll at least answer the test questions, right? Okay, so this slide is just a simplistic slide. It shows the cellular location of 5-HT autoreceptors, and one reason this slide's right here is because I'm going to come back to this when I talk about migraine drugs. So the 5-HT1 receptor class, and here we got a 5-HT1D, there's A, B, C, D. 5-HT1 receptors are often found presynaptically, right? They're here, presynaptic neuron, and they couple to 5-HT1 receptors couple to GI, right? And so when they're activated presynaptically, what's that going to do to 5-HT? What's that going to do to 5-HT release? It's going to decrease it, right? So, and this is one way the system can try and keep itself in homeostasis. Too much 5-HT is being released, it's going to feed back and activate those autoreceptors and decrease 5-HT release. Okay, and in terms of the GI system and serotonin actions, serotonin is made in enterochromatin cells, which are located in the GI mucosa. These guys synthesize 5-HT, and they also synthesize autocoids. You guys know what autocoids are involved in? I don't know that term doesn't get used a lot, but we have an autocoid section in this semester. They're inflammatory type molecules, okay? So these enterochromatin cells, though, they make 5-HT, and the 5-HT is released from them when the gut gets stretched, okay? So they're involved in satiety signaling, okay? And among other things, when the gut gets stretched, these enterochromatin cells are stimulated to release their contents of 5-HT. Among other things, that's going to help. 5-HT is then going to have actions in the gut to help regulate motility. Okay, and it can enhance or inhibit motility depending on which receptors in that area of the gut are being expressed. So this slide shows an enterochromatin cell. Okay, so 5-HT again is made in these enterochromatin cells. I was just writing the test, and I'm pretty sure I wrote a question about 5-HT being made in enterochromatin cells, right? So 5-HT gets made there, and then when the 5-HT, when these things stretch, when the gut stretches and these things are activated, they're going to release 5-HT into the gut lumen, okay, where it's going to have actions. Okay, and also it can release 5-HT into the circulation, and 5-HT can be taken back up into these cells from the circulation. Okay, so they're almost hormonal type signaling. Okay, 5-HT3 antagonists and 5-HT4 agonists get used to treat GI disorders. And when we talk more specifically about GI disorders, we'll talk about these guys more specifically. But I think at this point you want to know these two receptors are targets of drugs for GI issues. So, and as the slide shows here, we've got 5-HT with here's so these what's going on? Technology issues. Okay, these are supposed to be enterochromatin cells, right? These things. So when you've got pressure, other stimuli, got stretches, they're going to release 5-HT. So that 5-HT, among other things, is going to bind sensory neurons, okay, in the gut, and they'll bind 5-HT3 receptors. I don't know how well you can see that, but 5-HT3 receptors on these sensory neurons in the gut, and when that 5-HT gets released from the enterochromatin cells, going to activate these sensory cells, and they're going to send signals to the CNS, signaling gut's getting full, right? Okay, and then also there's 5-HT4, so there's that 5-HT4 receptors are also involved in more local gut regulation. Remember, enteric nervous system is the quote-unquote nervous system of the gut. That might be a test question, just so you know, enteric nervous system. But there's 5-HT activity there as well, and largely 5-HT4 receptors that can be found presynaptically involved in enteric nervous system regulation. And as I said, 5-HT4 agonists can be involved in regulating that, and so you can use them to help like stimulate motility, that sort of. And again, we're going to come back to this stuff. In terms of 5-HT in blood vessels, in vascular smooth muscle, direct 5-HT application is going to have a vasoconstriction effect. However, 5-HT can also stimulate nitric oxide production from endothelial cells, and that nitric oxide, what's that going to do to the smooth muscle? It's going to cause it to relax, right? So it's kind of the vasculature really can get a mixed bag sort of effects. It just depends on what receptors are expressed in the specific tissue. At the level of platelets, and we're going to come back to this again this semester too, platelets express 5-HT2A receptors. Platelets take up and store and release serotonin. Okay, and then when platelets come in contact with the injured epithelium, so when you need to form a blood clot, that sort of thing, serotonin gets released from the platelets. The release is actually secondary to other subjects, but what happens here is the serotonin is going to interact with other substances to aid in platelet adhesion, aggregation, and thrombus formation. Okay, this slide shows the 5-HT actions at blood vessels. So, and here you've got a vascular injury, cut yourself or what have you. There'll be some initial platelet aggregation, but again, these platelets have 5-HT in them. They're going to release 5-HT, and that 5-HT is then going to bind 5-HT2A receptors on the platelet. So it's an auto signaling action we've got going here, and that's going to help accelerate platelet aggregation and thrombus. You can also get 5-HT1 receptor activation on endothelial cells, and you get some release of nitric oxide, et cetera, that can cause vasodilation. But really, in terms of the coagulation, et cetera, the bigger effect is going to be down here, binding of 5-HT. These are 2A receptors here, where you're going to get vasoconstriction. That's going to help, keep the blood flow from knocking out your forming thrombus. Okay, so 5-HT is involved that way. This slide is kind of a slide that has all kinds of different actions of 5-HT in the CNS, and you learned all that stuff last semester, so I'm not going to do anything there. Okay, just briefly, there's some 5-HT receptor agonists out there, of course. They have a bunch of different chemical structures and pharmacological properties. Have you guys done that yet with Dr. Taber, any 5-HT? Did he do that this week yet? Okay, he will. And as you know, 5-HT1A agonists get used to treat anxiety. In fact, Teeter was just telling me this yesterday, that you were saying, no, actually he was talking about adrenergic receptors. But I'm assuming he's going over this stuff now in therapeutics, right? Okay, 5-HT2 agonists, these are the ones that are going to cause hallucinations and that sort of thing. You've all heard of LSD, right? The way LSD causes hallucinations. Of course, LSD binds a lot of different 5-HT receptors very avidly, but the hallucinations, etc., from 5-HT2 receptor activation. And again, 5-HT4 agonists get used to treat GI disorders. Okay, and that's the really quick and general 5-HT in the periphery kind of warm-up lecture, as it were. Next 10 minutes or so, I'm going to briefly go over migraine pharmacology, just so you've at least been exposed to it before you get to therapeutics. Okay, so you know a lot of people out there have migraines, and I've never had a migraine, but apparently they're very debilitating, right? I'm sure there's, I think it's 10% of the population gets migraines, so I'm sure there's several of you who unfortunately suffered from migraines. Serotonin agonists are useful for treating migraine headaches. In general, bigger picture though, 5-HT is just one of the neurotransmitters, or one of the transmitters that's involved in migraine initiation. So you got serotonergic involvement, noradrenergic involvement, and also thought to be some glutamate and nitric oxide involvement of generating migraines, and this actually happens. The generation of migraines is thought to actually happen within the CNS. Migraine itself is not within the CNS, the cause of migraine pain. Okay, so what happens with initiation? You get brainstem noradrenergic and serotonergic projections to the occipital lobe, and the big thing here is, and you need to know this in terms of migraines, because this is where they really start, is trigeminal nerves. Okay, you start to get dysfunction here at the outset of migraines. But what happens, as we'll see, the trigeminal nerves, the trigeminal nerve dysfunction, and that leads to changes in, among other things, in cerebrovascular tone. Okay, so what happens with migraine initiation is, again, you get these trigeminal nerves are activated, and they go to the periphery, and among other things, trigeminal nerves innervate blood vessels, right? Blood vessels like in the dura mater, that sort of thing. So what happens is you get activation of these trigeminal nerves, and they release serotonin. They also can release neuroactive or vasoactive neuropeptides. Okay, and it's those vasoactive neuropeptides that are thought to be the culprit in migraines. They're acting at the vasculature, of the head, and they're causing inflammation, etc. So, and then, of course, that gets sensed, and those signals get sent back into the brain and processed as pain signals. Okay, so this slide shows the location of trigeminal nerves. The big thing for us in terms of migraines is the nerve endings here. This is it's not in the CNS, it's peripheral nerve endings, okay? So those guys get overexcited. When the neuropeptide, so when the trigeminal nerves are overexcited, they're going to release 5-HT onto that cerebrovascular. They're also going to release these vasoactive neuropeptides, and that's thought to stimulate vascular inflammation and release of chemical signals that are associated with it, like prostaglandins, that sort of thing, and that's where your migraine pain comes from. Okay, I have a couple slides. Because of the brevity of this, I'm not going to be so concerned yet. You understand that migraine initiation, but at a very simple level. So migraines are thought, again, to initiate within the CNS, okay, even though the pain is outside the brain itself, as it were. So you get, what happens though with migraine initiation is in the brainstem you get this dysfunction of 5-HT and norepinephrine activity. That, among other things, is going to activate trigeminal nerves. Okay, those trigeminal nerves are going to then release their 5-HT and vasoactive peptides onto the vasculature. Okay, and then back inside the brain, well, what happens is the cerebrovasculature, in terms of sensing the pain, and this is the part I'm not so concerned you really understand or study, but those signals get sent back into the brain into areas like the trigeminal nucleus caudalis, which then sends signals to other areas of the brain, including areas that are involved in photo and phonophobia. So when somebody has a migraine, right, a lot of times they'll want to stay in a dark room because light irritates them a lot, that sort of thing. That's because you've got this feedback coming back into the CNS, and you're getting activation of these areas of the brain that are involved in sensing that, and those areas get overactivated. So things like light, etc., can really bother folks with migraines. Okay. Signals also get sent to the thalamus and then relayed to pain centers in the brain. There's also signals that get sent to nausea and vomiting centers, so apparently people with migraines with nausea and vomiting, that sort of thing. So, and that's all happening at the level of CNS, but again, the initial, where the pain is really coming from is from that vasculature. Okay, and then this slide, just in a really stupid way, shows the vascular, emphasizes the point that the migraine pain is from that vascular dilation that's being caused by trigeminal nerves secreting 5-HT, but more importantly, neuropeptides onto the cerebrovasculature. In terms of treating migraines, there's the two guys, there's many ways to try and treat migraines. Of course, we use NSAIDs, acetaminophen, antiemetics, because people, their nausea and vomiting centers are being overactivated. But the two guys we're interested in for this abbreviated lecture are the red ones, Ergot Alkyloids and Triptans. They both work the same way. They're both 5-HT agonists. Okay, so Ergot Alkyloids, just briefly, mechanism of action. These guys are fairly complicated, but in terms of migraine and why they're thought to be effective, that's step number one. They bind 5-HT1D receptors on dura mater and cerebrovasculature. They also, though, activate 5-HT and 1B receptors on, and this is really the big point, presynaptic trigeminal nerve endings, right? Remember, these receptors found presynaptically, they couple to GI. So when they're activated, you're going to get reduced activity. So what's happening here is you're presynaptically reducing the amount of 5-HT that's getting released from those trigeminal nerves. Or also, by this presynaptic action, you're decreasing the amount of the vasoactive peptides, these neuropeptides that are causing the inflammation. That goes down as well via this presynaptic activity. Okay, there are other actions, as is shown on the slide here. But briefly, going to the receptors, they activate 5-HT1B and 1B receptors. These are, again, G-protein coupled receptors, coupled to GI. And they're found in the cerebral and scalp vasculature. They're also found throughout the brain. And again, the big thing is these receptors are located presynaptically on 5-HT neuron terminals. And when they're activated by an agonist, you get a decrease in secretion because the agonist is activating a G-protein coupled receptor that's involved in decreasing cyclic AMP second messenger signal, okay, lowering activity. Okay, and this slide tries to show this in a real simple way. So here we got a trigeminal nerve ending. Trigeminal nerves firing because we've had other activity in the CNS that are involved in the generation of these migraines. So the trigeminal nerves are activated. Trigeminal nerves are going to secrete serotonin and these vasoactive peptides. And this is supposed to be a blood vessel in the dura mater scalp. Okay, and so what happens initially is you're going to get this, largely via these neuropeptides, you're going to get this increase in cytokine secretion, et cetera, and you're going to get inflammation of that vasculature. And this is supposed to just be a blown up version of this. I don't know what I was thinking. So anyway, so that's what happens, but then these 5-HT agonists that are used to treat migraines are going to couple. You're going to bind these GI coupled receptors here, and that's going to reduce this business, right? Okay, and then this slide just shows triptans. Triptans work basically the same way, okay? And so I'm not going to spend a lot of time on it. They work basically the same way. This slide summarizes migraine pharmacology, at least for triptans and ergot alkaloids, I think, pretty well. It's pretty simple up here, and I don't know how well you can read it, but this says trigeminal sensory afferent nerve fibers that are sending, when they're activated, of course, cause the release of these vasoactive peptides onto the vasculature of dura mater, scalp, so you're getting inflammation there. Okay, and again, so this shows some of the agents that are being released. I'm not going to worry about that right now, but with ergot alkaloids and triptans, you're working presynaptically to produce that. Hopefully that's clear. Okay? And so that's the very